Moving on, we will now discuss the next subtopic, that is microbiology of genitourinary tuberculosis. Here, we will be discussing about the various causative organisms that can cause genitourinary tuberculosis, how exactly these are being identified, how exactly these are being cultured, what are the various culture methods that we adopted earlier, and what are the current culture methods that we are adopting these days. Everything will be discussed under the heading of microbiology of GUTB. Okay, so now we will recap what exactly we had discussed earlier. We had a patient who was 35-year-old male who predominantly had loss of appetite and loss of weight with evening raise of temperature. Also had storage urinary symptoms for 3 months duration. Had a history of treatment 15 years back for pulmonary tuberculosis with antituberculous treatment. The clinical findings were largely unremarkable and we had a working diagnosis of GUTB made. So with this background, what do we do next? The next thing we will do is to do the regular routine biochemical investigations. Hemoglobin was 12.5 grams, total count of 10,600, differential count predominantly lymphocytosis, and ESR, if you see here, ESR is 107 millimeters per hour. It's very important for you to remember this. ESR of more than 100 is something which we'll have to concentrate upon. The urine routine analysis, if you see, the pH was 5.8, a little bit of acidic urine, and pus cells were 12 to 14 per high power field. Urine culture showed no growth and urine smear positive for acid fast bacilli. When we did 3 consecutive specimens of urine for AFB, they were positive for acid fast bacillus. So what are all the catchy positive findings that we have in this? ESR more than 100, number 1. Number 2, we have acidic urine with pus cells, that is pyuria with no organism grown in culture, that is sterile acidic pyuria. So high ESR, sterile acid pyuria, and urine smear positive for tuberculosis, that is AFB positivity. All these point towards a genitourinary tuberculosis. When we talked about, I was emphasizing on this high ESR. So ESR of more than 100. So what is ESR? Why do we know? Why do we need to know about this elevated ESR? So what is ESR? It's a non-specific screening test which indirectly gives you some sort of a measurement of how much of inflammation has occurred in the body, as it reflects the tendency of RBCs to settle more rapidly. The rapidity of settling of the RBCs clearly point towards the number that we get from ESR, how many millimeters of sedimentation of the erythrocytes happen per hour. So higher the rate of sedimentation, more serious the condition is, or more severe the degree of inflammation is. The 3 events that happen in the ESR testing is, as we all know, we have a Wintrob's method and Westergren's method. I am not going into the details of what this Wintrob and Westergren are. The widely popular one is the Westergren method, where we have a larger tube, about 30 centimeters tube, and the 3 events that mainly happen in ESR: degree of aggregation, degree of sedimentation, and the extent of packing of those RBCs. No? So that decides how many millimeters of RBCs get sedimented. Now 100 millimeters per hour indicates that these patients can have only 3 of the possibilities. I should not say only 3 of the possibilities, more commonly 1 of the 3 possibilities. The most common one is tuberculosis, malignancies, and myeloma. Patients with multiple myeloma, or any cancer for that matter, or tuberculosis. These are 3 conditions which characteristically present with very highly elevated ESR level of more than 100 millimeters per hour. It's important because the reason why they develop such a high sedimentation is because the dysmorphic RBCs, the crenated RBCs, the high levels of plasma proteins, they all cause an increase in aggregation, sedimentation, and the packing of these erythrocytes, resulting in a higher ESR in tuberculosis. The next one is sterile acid pyuria I was talking about. No? What exactly is this urine analysis? When we look at the urine under a microscope, when we do a urine microscopy for that matter, the volume of urine that is usually under a cover glass. Here, when you have a cover glass, the urine that is placed under the cover glass will be about 0.01 ml only. That is 1/100th of an ml is what we actually screen under the microscope. Please remember, if you take 1 high power field, you will see only about 1 by 30,000 ml of urine. That means the bacterial count should at least be 30,000 per ml of urine for you to actually visualize that under microscope, under high power field. The bacterial count should at least be 30,000 per ml of urine for you to see that under microscope in a high power field. Otherwise, there is a likely possibility that it may get missed out in one of those high power fields that you happen to see. And the negative urine analysis does not exclude infection, because any count, colony count, which is less than 30,000 bacteria does not necessarily be shown in your urine microscopy. So negative urine analysis never excludes a less than 30,000 count of bacteria. And false negative urine analysis is usually seen in patients with low bacterial count of less than 30,000. So false positive urine analysis may also be seen with your lactobacillus, corynebacteria, vaginal flora, etc. So please remember, you can get false positivity with lactobacillus and corynebacteria. You can get a false negativity despite having an infection if the count is only less than 30,000 per ml.